Good afternoon, everybody. Again, as Shannon said, it's my pleasure to introduce Dr. Parinda Khatri. She is the Chief Executive Officer at River Valley Health, which is a qualified health center and licensed community mental health center that provides comprehensive and integrated primary behavioral health, dental, vision, pharmacy, and outreach services to nearly 70,000 patients across 25 counties in Tennessee. She serves on several national boards. She's been awarded the Susan P. Smith Award of Excellence by the Tennessee Primary Care Association, the Don Block Award by the Collaborative Family Healthcare Association. Not a big word. We don't use these big words on television. The Excellence in Education and Teaching Award by the Society of Health Psychology, and is a fellow of the Association of Clinicians for the Underserved. I'm proud to say that I am a longtime member of her board, and also very proud to call her my friend, Dr. Parinda Khatri.
Thank you so much. Ken is also my boss. As one of my bosses, I always say I have 10 bosses. I went from one boss to 10 bosses with a job. So thank you very much. I'm so honored to be here. I've heard wonderful things about this group. You know, I'm Ginny, and now I know every Tuesday you love to come here and feel so inspired. So I thought I would share a little bit about myself and our organization. So this, in less than 2 months, will be my 24th anniversary at what is now River Valley Health. So whoops, did this go next? I need to go back. Oh, it's just going on auto. Oh, you were checking. Okay, I'll just say, and go to the next slide. So 24 years, my first day was September 11th, 2001. And I was trained as a licensed clinical psychologist, and my first day going to go, and I was embedded in our primary care clinic, and this was one of our clinics in our clinic in Maryville. And so I started at 8 o'clock in the morning, and then pretty soon I felt there was so much hustle and bustle and frenzy. And I wasn't quite sure. And then someone said, there's been an attack. But honestly, I was so focused on seeing the patients who were coming in. And my eyes were open on what a community health center is to the community on that day, my first day. People thought the world was ending. People thought that we were being basically taken over by another country. They were terrified, and they showed up where they felt home and where they felt was safe. And that was at their local community health center. So I went from exam room to exam room, dealing with people who had panic attacks, who were terrified, and people who were in a state of anger. Like, who could have done this to us? The emergency room had been inundated at Blount Memorial, and then they found out, oh, there's a psychologist over there in the clinic, and they started sending people to me. So it wasn't until I went home that night that I actually saw all the footage. So what really struck me that day was how important it is to be a place that is a safe harbor, a port in a storm. And that is really our goal at River Valley Health, which is now Cherokee Health Systems. So now you can go to the next slide. So I started out as a clinician, and then I, over the years, became Director of Integrated Care and Chief Clinical Officer, and 3 years ago assumed the role of CEO. And I'm just very proud to say that we have been in service of the communities in our region for 65 years, a very long time. We started in 1960 in Morristown as a small community mental health center. Today, we have a continued mission to provide access to care for everyone. Ken had mentioned we're a federally qualified health center. The federally qualified health centers, we're not part of the federal government. We are a private nonprofit, but we are unique in that our charge is access to care. We are also patient-driven. Over 50% of our board, by law, have to be our patients. So when I talk with our patients and they ask me questions, I say, you own this organization. We are here for you. We are here for you. So as a federally qualified health center, we are required to provide access to care regardless of ability to pay. And so many of the communities we serve, no one else in the community will see them. In some of the communities we serve in rural areas, we're the only site because nobody wants to it's not profitable to put a health clinic in Washburn. In Washburn, you just see us because nobody else is there. So it is such a place of honor for us to be preferred provider, but also a safety net. What has happened over time since we started in 1960 is growth. So we started in Hamblin County, very small, open 2 days a week. 2 days a week, we were founded by the Federated Women's Club of Morristown. And this was their project that they kind of hatched, every year they had a project. I see you've got projects as well. And it grew. And our CEO, who was my predecessor, had really the mantra, Cherokee goes where the grass is browner. Wherever there is need, we will go. Our name at that time came from the lake. So those of you who know Morristown and Hamblin County, there's Cherokee Reservoir. There's a lake there. So when they had to come up with the name, and in East Tennessee, a lot of Western North Carolina, lots of things are named Cherokee. But because we had grown so much, we wanted to have a brand that reflected that growth and reflected our reach and the breadth and depth of our services. So this summer we rebranded as River Valley Health. Ginny was very closely involved in that. And we rebranded after doing a year's worth of work and asking our patients. And what we came up with was, number one, we live in this gorgeous, beautiful, rich area of Tennessee. And there are rivers, really rivers that intersect the area that nurture us. And they really provide a lot of nourishment and richness to the area. And that's what we want to do. We want to be a nurturer for the community. And we're also in the valley, and the valley protects the community. So we wanted to protect the community. So River Valley Health, RVH. We're still getting used to it. And it will, for those of you who still see signs with our Cherokee Health Systems name and logo, signs are incredibly expensive, as I was telling Ken. So give us about 4 or 5 years to get through all of that. So now today, what we've done is we now have 21 brick and mortar clinics that we're going to have 22. We're opening a walk-in clinic in the Mechanicsville community of Knoxville in the next 6 weeks or so. And we also have 20 virtual sites. The virtual sites are in Sevier County in the schools. The school system came to us in Sevier County and they said, we have a huge problem with absenteeism and problems with these kids when they get sick. Their parents are working in either Dollywood or a factory and they cannot get off work. They will be docked points without any planning. And then, Sevier County is like 2 hours from end to end. They will lose the whole day trying to get access to care. So we came together and we set up an entire telehealth system to 20 plus schools in Sevier County. When the kids start the school year, they sign an informed consent and their parents say, yes, you can see my child if they're sick. And we have 2 full-time pediatric providers that are on call for the students when they're sick, and also now the teachers and the staff. And so if a child is sick, the nurses are trained. We have otoscopes. We have all these monitors and equipment that actually beam back into our mothership, into the clinic. And our providers will say they love it because they actually can zoom in on a throat They can hear much, they can see inside an ear. That prescription gets written, it gets sent to the pharmacy. So all the parents have to do is come pick up their child and pick up a prescription if that's warranted. So again, we want to be innovative problem solvers and finding ways to bridge access to care. We also recently, it was during the pandemic and over the past 2 years, have 2 mobile clinics. These mobile clinics, one we call the Urban, that mobile clinic is under the bridge. It goes to churches. It goes downtown to Carm and the different sites where there are communities that typically would not have access to care. So we're able to bring through telehealth and our on-site mobile clinic a pretty wide range of clinical services, including behavioral health and medical care. And there's one rural mobile clinic, and it will go out into the farms. It goes to the mushroom plants and factories in Loudoun County. It will go into Cobb County. During Hurricane Helene, that mobile clinic went to Hartford. It went to we parked at gas stations at the edge of the flood zones, and we were literally delivering insulin and medication, wearing rubber boots to the elderly in that area who could not get access to medications because the Walgreens was completely flooded under. So those mobile clinics have been a tremendous lifesaver for us and for the community. So when we look at our service area, we see patients from 25 counties in East Tennessee. And we actually also have people who come over a little bit from Georgia and down in Kentucky. So we go all the way up, as you can see, up to Tazewell. There's a certain part when you're going to Tazewell, you lose all cell phone service. So we all know that we have to be careful when we go there, but we have a clinic in Claiborne County, and we've got patients who will literally cross over the mountain to come to see us from there. So now we can, next slide. So I thought it would be interesting to talk a little bit about how we became who we are now and what we're looking at in the future. So if you look at our first 14 or so years, we were a true community mental health center. At the time of our founding, the focus was getting access to mental health services for people, because that's really what was missing. Here's what happened. So if we look at, we did behavioral health, psychiatry, substance use treatment. We were driving patients into the clinic. What happened was we started noticing that our patients were dying. And they were not dying of overdose or suicide. They were dying of heart disease and diabetes. But nobody wanted to see our patients with mental illness for medical care. They would literally just say, I don't want that patient in my waiting room. Those patients are too complicated to talk to. Nobody wanted to see them for medical care. At the same time, as we were going out into our, Cherokees, that goes where the grass is browner, and we were expanding and doing outreach into areas where they did not have mental health, our CEO, Dennis Freeman at the time, he's notoriously frugal, very frugal. He did not want to rent space, buy space. So he would go to doctor's offices and say, can I just have a little office here to see patients with mental health issues? And we'll be off in the corner. You don't need to worry about us. And what he found was there was just as much psychopathology and need for behavioral health in those communities. And they were never going to go to a community mental health center. They were just not going to access. There's so much stigma. And so he started connecting those two. So when I came on board, by that time, we had already built out some medical care. And we had probably about half our sites with medical care. When I came on board, as you can see, I started out in a primary care. I was in the medical clinic seeing patients. And we started building a model of integrated behavioral and primary care where people could get both of those services, and the care team members actually talk to one another. Can you imagine that? How many times have you wished that you were all the different doctors? You're like, can I just like, can you talk to each other? And with our patients, they would not know what meds one person put them on, what were the labs. We have one shared record, and communication and collaboration, coordination is absolutely essential to our model. We started launching new services. I was able to be part of a Children's Hospital Leadership Council early, I think it was around 2010 or so. And I got to visit the NICU, and this was the height of the neonatal abstinence syndrome, where these infants were being born dependent physically on an opiate. And that is the most heart-wrenching, gut wrenching experience of my life, to see these little ones. And then I just left there thinking we have to do something. So we recruited an OBGYN. That OBGYN had been working at UT and UT Medical Center for 25 years, wanted to do something different with his life. We started working with our substance use counselors, our therapists, our other medical providers, and we built an integrated care team for women who were pregnant and dependent on opiates, with the goal that we were going to get them off the opiates so we would not have the baby born with NAS. And that's what we did. We expanded into pharmacy because our patients could not afford medicine. We then moved into health professions training. I always say we kind of had two main drivers for everything we've done. One is this mantra, we go where the grass is browner. The second is desperation. Really, some of the most innovative things are things that people kind of ask, how did you come up with that idea? I just say, we were desperate. And one area we were very desperate was workforce. The work we do is not easy. We are with people who are struggling with many, many barriers to healthcare, many barriers to healthcare. And they are in tremendous suffering. Many of them are very sick, very complex, and it's not an easy gig. And healthcare is expensive, and hiring healthcare workers is expensive. So we just started growing our own. We developed multiple training programs. We partnered with local universities. We have a very strong partnership with UT, as well as other local universities. And we started growing our own, developing training programs, medical assistants, psychologists, residents, thinking that maybe if they were with our patients, maybe if they were in this space, working with other people who were mission-minded, that they would fall in love with it and they would stay. And they would give up the higher paycheck and all the easy days and say, this is where I'm being called. This is my purpose. And it has done fairly well. It's harder right now, but it has done fairly well, where I will be honest with you, our training programs in the pandemic saved us because people stuck with us in one of the most challenging times in our history. So we now are an area health education center. We've been identified as a national exemplar of a learning health system. And then over the past 10 years, we have expanded even more. We added optometry because so many of our patients did not have access to vision care. Many optometrist vision providers, particularly in rural areas, do not take TennCare. They definitely don't see people who don't have insurance. One of the most uplifting and heartening things is when you have someone who's like 66, 67 years old, and they are coming in to get glasses for the first time, and they've never been able to afford vision care, and they're able to see, and they will look and they'll say, they'll rush over to the window and they'll say, can I see my car? Look at the leaves. The first time, and I sometimes I'm like, they're driving. We're going to be, so we added optometry here. We're going to add optometry in Hamlin County. There's not a single vision provider in Hamlin County. that will take tent care. We have added dental. Dental is a huge need, and we're expanding it quite a bit. Now, again, these are things we have to make work. And we make it work because our payer mix is, you know, a tough one. But what we believe in, we're very mission oriented. We have strong faith that if we're doing the right thing, we will always find the money. We will find the money. So just really quickly, our community gardens, and shout out to Ginny. The community gardens have been, I just said, let's do a community garden to honor the legacy of our previous CEO who has since passed. And we did. We now have 4 community gardens. 3 of them are run all by our patients. They are managed by our patients. They learn how to make healthy foods. They make lunch. Then any excess produce gets given to the community. So they'll just put it on a table every day. And then we have some farmers in our community who will come and compare their produce to our produce. So they can get a little bit competitive, I will say. And then finally, I do want to highlight our Get Well Now. Our Get Well Now is a walk-in clinic. One thing we realized is, and we probably realized it a lot later than others, is that with this, there's this idea now of I want what I want when I want it, with Amazon, etc. Why shouldn't healthcare be the same way? So we partnered with Helen Ross McNabb and the city to open our first Get Well Now clinic, which is all walk-in. 50% of the people who walk in for care have no insurance. The other are kids, parents with young kids, and they don't want to take their kids to the emergency room. So 70% of the people we see in that clinic, when we ask them, what would you have done if we weren't here? They would say, we would have gone without care or we would have gone to the ER. But neither of those things are a good path. Next slide. I'll wrap up in just a minute. I wanted to highlight, this is our data from 2024. You'll see that a full 25% of our patients had no insurance. In Knox County, it is 34%. Over a third of the patients we see in Knox County have no insurance. We're expecting that to go up next year substantially. 40% or so are Medicaid or tent care. Last year, we provided over $14 million in uncompensated care. Next slide. I also thought it's important to see what our role is in the community, and I hope you can see it. I will just highlight one of the things we've done is we've partnered with some accounting firms and financial firms that actually have these sophisticated algorithms, and they pull all kinds of data. They get our data, they get community data, and they say, what is the impact of your health center on the community? And in our area, you'll see powerfully how many jobs we are creating, what is the economic stimulus in terms of tax revenues, in terms of community spending, but I think most powerful is the savings to the system. Healthcare is in a very, very dark place. Right now, we have the highest, most expensive healthcare system in the world, and one of the poorest health outcomes. But guess what? Community health centers are the opposite. We are a great deal. And that is being recognized. We have bipartisan support. We're one of the few things that everyone across the aisle can agree on because we report a lot of data. We are an awesome deal. We are an awesome deal because our focus is good quality care and high value care. In East Tennessee, we save 24% of the healthcare cost, and to the overall health system, it's $112 million. We save the overall health system. In Knox County, we save the health system in Knox County $54 million. That's not a small thing. So finally, in the last slide, just in terms of our role in the community, yes, we are a preferred healthcare provider. We want to be a safety net. We are also a resource for health-related social needs. Every one of our clinics has a food pantry. We give away diapers. We give away clothes. give away a lot of things. We work with patients in our supported employment program. We work with patients with mental health issues who want to get back to work. So if anybody is wanting to partner with us in our supported employment program, we would love to talk with you. But we're also a collaborative partner. We work with Emerald Youth Foundation, UT, Second Harvest. We are an employer. We've got a great team of mission-minded people, and we are an economic driver. So as you can see, we're very proud of our role in our community and really honored to be part of this great community. So thank you. You talk about that 14 million and uncompensated money. Where are you getting that money from? Yeah. So we get it made up in a couple of ways. One is we do have a pharmacy. And so that pharmacy revenue helps to offset the cost. And that's probably our biggest driver. We do get some grant funding. We get some grant funding from the state. It's not much, but it's something. And we get some federal funding. It's nowhere near the amount, but everything helps. So it really is a combination of grant funding, donations, and our pharmacy. And so that's something that we're looking to expand. And that's why we've done home delivery for our pharmacy and mail order pharmacy. But that honestly, that helps keep us whole with the uncompensated care. Is there anybody who turn away like this? We don't turn anyone away. We want everyone to have access to care. The only time we wouldn't see someone is if this doesn't happen often, but if someone has been violent or aggressive with our staff or the other patients. And that does happen, but that's not okay. And so if someone shows a pattern of aggressive behavior in our clinics, then we just tell them we're really not the best place for you. So.
Why do you expect the number of uninsured patients to increase next year?
So that's a great question. So there have been a number of marketplace credits. So there have been credits that have been in the system. So people are able to get health insurance at a very, very low cost. Those credits are expected to end in December. They were going to expire in December. I don't think there's any appetite to continue those. And so already what they're saying is those premiums are going to go up by about $10,000, which none of our patients could afford an extra $10,000. So we're anticipating, when you looked and you saw that 22% commercial, most of that commercial is from the marketplace plans, the ACA plans. And so that will convert probably to uninsured. So all of us across the country, but particularly here in Tennessee, because we have a lot of people on the marketplace plans using those credits. So a lot of the community health centers across the state, we're all calculating how much more we're going to get in uninsured.
In talking about working in the rural community and getting some positions from like sort of the flashy high paid jobs, are y'all doing any recruiting, I guess, from like UT or LMU for student loan repayment for working in a rural area? Because I think there's some loan repayment options for that.
Yes, that has saved us too. Okay. So you can get loan repayment through a program. If you are in a rural area, medically underserved area, our biggest issue is you get it for like 3 years. And for many people, we have that 3-year window to keep them. And what's hard is because we have such a high uninsured rate and, a high Medicaid population, they're like, I could be making, $200,000 more. I mean, it's not even a little bit more. And it's not just with our physicians, it's for our nurses, our front desk staff. People are not leaving for like 20 cents more. They're like, I can make $17 more an hour. And I'm like, there's nothing we can do. So, and in some of our areas, our biggest competition is like Chick-fil-A or whatever. I mean, you can increase the cost of a Chick-fil-A sandwich. We do not increase the cost of our sliding scale. So, I mean, I bought many a Chick-fil-A sandwich. I have 2 adult boys, but they love Chick-fil-A and I'm like, it used to be like $4 and now it's like $8. So that's the thing, is that we don't raise our prices. Our sliding scale fee has stayed the same. And Ken will tell you every year we look at the poverty guidelines, the official poverty guidelines, and we realign our sliding scale to the official poverty guidelines, but the amount people pay stays the same. And if you are unhoused, if you are homeless, you pay nothing. I mean, they don't have, even if we charge them, they don't have anything to pay.
What is your annual?
So last year, our annual operating budget was about $80 million. Mm-hmm.
It seems to me that if an uninsured person comes to you for care at one of the walk-in clinics or what have you, it costs your practice some money,
Yes,
but not as much money as if they went to the ER and got the same care.
for sure.
Do any of the commercial health systems, Inova, Covenant, UT, do they contribute to some of that savings to your budget?
Not at all.
Have you asked?
Yes. So I meet with, and I'm friends are all very nice. I'm friends. We meet with, Tony Benton, Keith Gray, Matt Schaefer, Jim Vandersteeg. They do not contribute. And the argument is very strong that you would have your ERs be very full with patients who are uninsured or TennCare, because that also does not pay well. And there are a lot of places across the country where the hospitals will contribute. It's just never been, it's not been the culture here. And, I know they have their own financial struggles. So, yes, we have asked, and I'll just say they're all good people. They're all trying to do good work, but they're looking at their bottom lines.
Do you get to negotiate drug prices for your pharmacy, and then do you sell at the market rate to your clients?
No, we have what's called so we don't get to negotiate drug prices. The drug prices are what they are. However, because we have a special designation as an underserved healthcare community health center, we get special drug pricing. So we get drug pricing at the cost of what the federal government pays. And so that doesn't, for some drugs, there's no difference, but for a number of drugs, it's a huge difference. And so what we do is we give that at that cost. I think we'll charge maybe a $3 dispensing fee just to offset some of that cost. But that is one of the that's why we got into pharmacy, was because if you get this designation, then, and people meet the sliding scale, then they can get medications that would normally they couldn't afford, but for them it just may be $3. Yeah.
Do you have a partner with Remote Access Medical, the ramp clinics at all?
Yes.
Follow up?
Yes, we are their follow-up. So they'll come to us, and several of our staff will volunteer with RAM, but we'll say, anyone who you think needs to follow up, tell them to please come to us. Yes, hi.
Maybe it's just because I don't know anything about business, but you said your 14 billion or whatever is offset by pharmacy.
Mm-hmm.
And then you just described the situation where you're getting cut rate and
For the uninsured.
only on the uninsured.
Yes.
Okay.
Right.
Thank you.
Yeah.
Time for one more question.
Sorry. So I just brought up a point earlier that is really important. So you brought up a difference between maybe what may happen in other areas of the country. Will you speak succinctly to just how terrible our Medicare reimbursement rate is compared to
I think you just said it. It's very low. It's very low reimbursement. And when I meet with CEOs, I do a lot across the country. I tell them all, I don't want to hear you complain about money. I just don't. Come to Tennessee because we get just pennies compared to what you get in terms of reimbursement. And then they'll have like a 4% uninsured, and I will just say, please, come on. We're 25% uninsured in our entire system. You don't complain to me about that. Yeah. I don't want to end with that. I will say, but what I will say is we do what we do because we believe in it. It is what we're called to do. It is our mission. And as I tell all our staff, and I believe strongly, it's never easy, but it's always meaningful. And that's what's important.
Okay.